Welcome. Thanks for being here. Real quick, I am Howard Fidler. I've been in practice 21 years, graduate of this fine institution when it was in the hood in 1997. I practice in Minnetonka, Minnesota, which is just outside of Minneapolis. I keep a real small home clinic there, and I primarily do travel to treat work with elite athletes. Everything from boxing to MMA, NHL, NFL, Major League Baseball, you name it, I've probably done it. I'm the medical director for the United States women's bandy team. If you don't know what bandy is, I'll explain it later. But I was just over in China with them this past January for 10 days for the United States team. We played in the World Championships. I've been a head chiropractor at the Maybee games for the United States national team in Israel. I was, to my knowledge, the first student credentialed to treat at a Olympic event in 1996 with the United States fencing team. It's Dr. William Tuttle, one of my mentors, teachers here, was the medical director. You know, and as you treat athletes, especially for me, the thing I learned real quick was I better own extremities, because 90% of the things I was seeing were not spinal, all right? And I was seeing some real cool stuff, and a lot of stuff I had very little clue on how to treat at first. I learned a ton from, like I said, from my mentors, and through the years put things together. What we're gonna go through is a systematic way of assessing, all right? I'm gonna show you how to adjust these joints, but there is no technically wrong way, unless there's certain things that might be, and I'll go through those if I think they are. But the point being is my way to adjust is not the way to adjust. Everybody is different. You're going to come into situations that are different, and as I've explained many times this morning, if you're going to be a sports chiropractor, and especially with the stuff I do, a lot of on-site stuff, you need to be a Marine. You need to improvise, you need to adapt, you need to overcome, because things change like that. And you're gonna come into situations where you go, the hell am I gonna do that? And for me, one of the prime examples, first time I worked with World Wrestling Entertainment, and I got to adjust Mark Henry. Now, if you don't know who Mark Henry is, former strongest man in the world, 1996 Olympic powerlifter. Dude has a 69-inch chest, right? Laying on his side, he was about here. And I had to step back and go, there is no way in hell I can adjust his low back and side posture, because I will hurt myself. And he was like, Doc, you're not gonna hurt me. And I was like, Mark, I ain't afraid of hurting you. I'm afraid of hurting me, dude. You're 415 pounds. You're a behemoth. So what did I do? I looked at him, I said, all right, come here. He goes, what? I said, kneel and put your chest right there. I created a knee chest board and freaking adjusted his lumbar's prone. You know, no, I'm a fucking Marine. Those guys wouldn't even, they'd have looked at him and gone like this. Wait, it's cool. Shit, tours don't work for WWE, trust me. We keep those guys out. You know, so we're gonna go through again a very systematic way, and the things I've learned and that I teach, I've taken through the years from going through Titleist Performance Institute, going through SFMA, so it's pretty much a connection there, and his name's Greg Rose, all right? That is the guy I took a lot of my ideas from, because when you look at SFMA, has anybody gone through it? Cool, so you know what happens. We start here, and then we test. Do they pass the test? No, stop. You don't go further until you clear that, and then you go to the next, and if they're clear, you go here, stop, but you keep going through systematically. Well, same thing in TPI, in Titleist Performance Institute. So I just adapted that to extremity work. And you know, what we're gonna do is basically go through a kinematic chain, because that's how extremities respond. And we're gonna go lower extremities. So, talking about lower extremity, what is the most common injury to the ankle? What kind of sprain? Inversion, exactly. You'll see some eversion. 98% of what you're gonna see is inversion, okay? Where are you gonna see a lot of everted sprains? Dancers, ballerinas, okay? They are a pain in the ass to work with, all right? But I do it, and they're fun, but they're a pain in the butt. Inversion's a lot easier. So starting off real quick, does anybody have an ankle issue that they're dealing with? Otherwise, I'm just, yep, come on up. Kid, I always love when I got somebody to start with. Makes it much easier. We ain't fucking with Dale. Okay, so lay on your back, shoe off. Both shoes off. Okay, so when we look at the biomechanics of an inversion sprain, all right, and we'll see it very commonly, obviously, when people are walking, okay, the first thing that happens when the foot inverts, okay, like that, is at the talocrural joint, okay? The talus is going to shift superior and medial, all right? That starts a freaking domino kinematic chain that we're going to go through. Okay, so two things happen. That goes superior and medial, and the heel, the calcaneus, will actually ride superior. So the first thing, and I don't care what lower extremity complaint somebody comes to you with, think like you're doing SFMA and start here and work your way up, because you'd be surprised how many athletes I've had. I had a United States Olympic hockey player who they were ready to do hip labral surgery on because she had hip pain, all right, and had a finding. Okay, let me explain something. Hip labrum tears are kind of like low back MRI disc bulges. There are a lot of people that have them, and they are asymptomatic and not the cause of the pain. I'm doing pressure. I'm grinding the freaking hip into the femoral head into the acetabulum and doing this. She had no pain. How is it a labral tear that's causing your pain then? So we went back, cleared out the ankle and the knee. All the hip pain was gone. All right. So no matter what they present with, start here as far as checking things. So all I'm going to do, so what's the background with the ankle?
Sprained it more times than I can count.
Sprained it more times than you can count. Now, let's take another step back. He's an athlete. He sprains the ankle. What is the traditional thing that they want to do with the ankle? Right. Stabilize it and brace it, right? So they want to bring the foot back to neutral, but they haven't done anything about the biomechanics, all right? And as we go through things, and I can tell you, when they do this, it accentuates every other biomechanical issue that's going on. Now, I despise the idea that somebody has weak ankles. Unless they have torn the ligaments up, it's not weak. Oh, well, but they keep on rolling it and respraining it. Well, yeah, let's think about it. The foot's sitting like this, okay, biomechanically. So when they walk, and what's the first thing that strikes when you walk? The heel. Does it strike like this or does it strike like that? So it starts striking like that. Now you have the athlete that's running on improper biomechanics, and let's say not the best field in the world, boom, and they roll it again. So they want to do this. Now, biomechanically, okay, the other thing that happens is the tibia will rotate medial or internal. The fibular head, so if the lateral malleolus came anterior, what way does the fib head have to go? Posterior. If it doesn't, we see what we saw in Dr. Tao's class earlier today, that distal fibular fracture, okay? And now understand, athletes will play on a distal fibular fracture. Why? It's not weight bearing. It hurts, and they think they can get through it, and then it blows up later, and it sucks, okay? But they didn't do any more damage usually just by running on it. So we have all this internal derangement, and so that he doesn't become a pigeon and pigeon toe, the femur and the hip compensates and rotates externally, okay? But the problem is it tends to overcompensate, and that's why you see a lot of people with outgoing duck walking, okay? It all starts here. Now, the worst thing that happens, if the tibia is rotating internal and the femur is rotating external, what little problem that we see in a lot of athletes is on stress? The ACL. There is no reason for an athlete, a high-powered elite athlete, to have a non-contact ACL injury unless there's something else biomechanically causing that injury, all right? And I will take, because we're in Kansas City, Jamal Charles is the best example, all right? sprains his ankle one season, blows an ACL the next season. Comes back off the ACL, sprains the other ankle, following season, blows the other ACL out. Both times non-contact injuries. Both contacts, I guarantee you that ankle was not treated properly, not rehabbed properly, and the only other reason you'll see it, and we see this more in female, and understand, the incidence of female non-contact ACL injuries in the last decade has skyrocketed, all right? I mean, skyrocketed. And what we're seeing is they've got a lot of glute instabilities, okay, and weaknesses. So what'll happen is those glutes aren't firing properly, so the hamstring fires up at the ischium instead of centrally and distally. So when that female plants and stops, it didn't engage here. Boom, there goes the shearing of the ACL. But again, there was a problem, okay? It shouldn't just happen, all right? And it can be prevented. And what I want is if everyone in this room prevents one ACL injury from happening because you properly went through a lower extremity exam and treatment, that's a good thing, all right? Hopefully it's gonna be a lot more than that as time goes on. So all we're gonna do to check it, I'm gonna come in, and I'm just bracing just above the talus, all right? Little pressure on the Achilles, not a lot right now. We'll talk about that in a little bit. I'm gonna come on the calcaneus, I'm gonna bring them to neutral, and there is almost no shear there, okay? We come to the good side, there's a ton of AP glide. I mean, you can see that thing glides like a dream. This one, I can try all day long, it's not gonna move. Again, the other thing we're gonna see, I'm gonna feel the good heel. That comes down nice. That one does not come down, all right? Very easy to fix. Now, it is a quasi-long axis thing. It is more of a scooping motion when we do this. Why? Because if I can avoid affecting the knee and the hip, I want to, okay? I do not do one of these big wham things, okay? I do not gorilla adjust. All right, and for the younger students that don't know what that means, imagine if a silverback gorilla was taught how to adjust, what it would look like, okay? And there are people in this industry that gorilla adjust, and it drives me freaking nuts, especially if they're working with athletes, and I will call them out on it and say, you've never treated a hot knee on a big athlete. And they'll go, yeah, I have. I go, no, you haven't. Well, how do you know? I go, because you have a freaking pulse. They'd kill you, all right? Don't tell me you've done that on a 6'5", 330-pound NFL offensive lineman. I'm gonna call bullshit. Because I've seen it, all right? They'll barely, trust me, the bigger the athlete is, half the time the bigger the baby they are, all right? Some of my biggest babies are monsters, all right? This is gonna hurt. You want it to? I can make it hurt. You know, that's not what I'm intending, but, you know, I laugh. I mean, it's just so funny that they're like that. I mean, these are guys that beat the crap out of people and then they're afraid of an adjustment. So, again, to correct it, I'm gonna take 2 fingers, come right on the talus, right on the anterior portion. The other 2 are just going to brace. I'm going to bring it back to neutral. Little bit of distraction, little bit of dorsiflexion. There it goes. Full motion. You do not have to slam on these things, okay? To adjust the calcaneus, protect the Achilles, please. Okay, you'll see guys come in and they want to, you're going to tear an Achilles tendon. Okay, or damage the soleus or the gastroc. So I will come in and he's going to tell you there is pressure on this Achilles tendon. Okay, I'm not letting this thing move because I don't want the Achilles to move. I want the calcaneus to move. So I'm going to lock it down. I'm going to bring it just slightly inferior. And again, there it goes. Walk on that. Tell me how it feels.
Definitely can dorsiflex a little better.
Perfect. Break up into pairs, threesomes, foursomes, I don't care, and let's walk through it.
I asked 3 different people for this for you.
You're the best.
Thank you.
Yeah.
Sorry, I missed you. I was supposed to come down and interview or introduce you.
Yeah, it happens.
I'm so sorry.
So start subtalar. So come here. So brace this. You feel it just doesn't move well.
Yeah.
Okay. Easiest way to check it. Yep. Just, there you go. So you feel that lockout?
Are you you're out of Minneapolis, right? My name is Ryan Gates. I go to Northwestern.
Oh, pleasure.
And then the other one to palpate
So-
was
Calcaneus. So we're gonna just, for this, we're gonna support Achilles. We don't have to lock it down, just support it and just check in for your, but check it side to side. So feel what the good, relax, feel what the good one feels like. Because if you just feel this, it feels like there's glide there. But feel this one first,
So you
block the Achilles. You feel how really smooth that is? Now feel that one. See, it feels smooth, but it's not as smooth as this one, is it?
right.
That's why we always check good side versus bad side. Because on the same time, as Dr. Riddle will tell you, if you just check an ACL on somebody, I mean, we'll get people who say, oh my God, there's more. Oh wait, it's bilateral. I guess it's okay.
So the first one you're checking is a subtalar joint?
Yep, or the talocrural.
Yeah.
Yep.
That's like the one that's mainly for dorsiflexion?
Well, yeah, absolutely. And again, when the talocrural joint gets affected, all your lower body biomechanics are shot.
Yeah.
It's just going to domino. All right. So now we're going to correct it. So, yep, 2 fingers or 3 in your case if you need to. Bring it to neutral. No, this one on top of it. Yep. Dorsiflex, distract, scoop. There you go. Almost no pressure onto the hip.
No.
Now go back and repalpate it, or remotion it.
So you don't put as much pressure on this one?
Don't
as
need
this?
to.
Yeah.
You
So
don't.
usually you get a lot of...
How you even did that?
Welcome to gorilla adjusting.
I forgot how you even did it.
Boom, boom.
Oh, wow. Holy crap. So you just distract on that?
Yeah.
Oh, wow.
And just a little scoop. It's not. You don't have to slam on these things.
So if you had someone that like came in, like if they're doing like, you probably do like squat assessments and stuff like
Yeah,
that?
because I'm TPI certified.
Yeah. So you do like, so you like adjust there and then you do like some...
So think about it. You do the overhead squat.
Yeah.
Well, what's the problem? We know if there's no anterior shearing at the talocrural joint, it comes all the way up.
Yeah.
So yeah, that's where I always start. That's where all this got rolling in my head.
Yeah. Cool.
So now we're going to do heel. Put your fingers here. This is how I want you pulling or supporting that Achilles. Do not be afraid. Lock the Achilles. Distract. Pull, pull, pull until you feel end play, and then quick impulse. That's it. Now recheck it. Look at how easy that moves.
That's nuts.
Gentle,
Yeah.
right? Cool. Awesome.
Yeah, because I was trying.
Can I see how? I want to see how you're.
Well, you got a good last name, so
I
you
know.
know.
I was gonna eventually say something.
So can you just grab
Yes.
Yeah, I am having a hard time like just figuring out what.
Okay.
Okay.
Squeeze it. That is the pressure you want.
Okay, yeah, you need to squeeze way harder.
Okay. I mean, you're not going to hurt her.
Yeah.
Squeeze it. Bring it to end play. Quick impulse. I don't care which hand you do it with for this. Whichever one you're most comfortable with.
It felt better.
Okay. So it's just a lot more
Relax.
pressure through.
Still a little stuck. Relax this. There we go. There's the glide we
So
want.
you actually almost you cup it a little bit
Yeah.
more to get that leverage.
Sure do.
Okay.
Yeah.
Okay. That
Yeah.
makes sense.
Cool.
Could you show us how to the different ways to check the range of motions with it? I know you did.
So we're going to do 2 things. We're going to check subtalar or talocrural joint, and then we're going to check calcaneal glide. So just going to brace. These just support the heel. So I have something to move. Thumbs just below the talus, and we're just going to check glide. And there's not a lot of glide there. We've got glide. We have very little. Feel the difference?
Yeah.
So we got to correct subtalar, and then we got to correct, and you can even see how much that freaking it went to. Doop.
Yeah.
So who's gonna do it?
Yep. Cool. Okay.
So relax. Boom. Bring it to neutral. Distract. Scoop. Tailless. Distract. There you go. See how easy that was?
Yeah.
Now recheck the glide. Glide. Not P to A to P. For the calc, you're going to come in. I'm going to show you the pressure I want so you can tell him. That is how much pressure I want on that Achilles. Then you're just going to distract it to end, and it's just going to be a quick impulse. Grab it. More or less, good.
That's good.
Okay. There you go. Now recheck the glide of the heel. Oh, look how it moves. Get up and walk on it. Tell him how it feels.
They feel proportional now. They're just better.
Good.
You need anything?
Glass of water.
That's what I was thinking.
How we doing?
Doing pretty good.
Good.
I'm trying to remember. Is it
Okay.
the one with the, I was just retesting.
2 fingers.
Oh yeah, I wasn't adjusting yet.
Okay.
I was just checking the
Okay,
P-Day
so just
glide.
grab.
Okay. Yeah, that one's pretty stuck. And so this, you grip the Achilles and,
Come under.
oh, under.
Instead of on top, come
Okay.
under. You're going to get much better support.
Oh yeah, there you go.
You can control things from underneath. It's hard to control things from on top.
Okay. And then it's just,
And remember, you're going to check side to side. So when you do it, I want you to feel this so you can tell her. That is how much pressure I want on an Achilles before you pull it.
Okay.
So go ahead. I want you to put pressure, and she'll tell you.
good?
You bring it to end play, quick impulse. That's it.
Okay.
Nothing hard. And then oh, look. A calcaneus that moves.
Awesome. Thank you.
How we doing?
Just,
Been watching this.
Good.
I'll take this one.
So you're just doing check and calcaneal?
Talus on this
Okay.
one, and then also
So check tailor to check subtalar or talocrural. Support the heel. Thumb just below it. Lock above it. And we're going to check glide. Okay, that's moving pretty nice.
Like here?
Yep.
You moving just inferior or just
P to A.
P to A?
A
Okay.
glide, P glide. So
Yep.
you can watch. That glides.
Yeah. That
That does not.
Yeah.
So that
Okay.
subtalar joint needs to be adjusted.
You said the calcaneus was more so like E version,
Nope.
N version?
Nope. I to S. Or S to I. So you just but when you adjust it, okay? When you check it, a little bit of pressure. When you adjust it, you feel that?
Okay.
That's the pressure we want. You won't hurt it if it's like that.
Okay.
You do this and go like that, have fun. Call NCMIC. When you adjust it, you lock that Achilles tendon down. I want you to vice grip the thing.
I just feel like my hands are you had your was it this hand that was pulling on?
Doesn't matter. You can do it either way. Boom, 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 boom. I'm just always confident with my right hand being the dominant to check. That's just habit. No.
When you're adjusting, you pull it
Oh,
far?
the adjustment, I'm going to show you.
Okay.
It's more of a scoop.
Okay.
It's a distraction and a scoop. So when you would go to adjust it, You're going to come. You can abduct a little bit just to get some motion. Okay. 2 or 3 fingers, doesn't matter. Right on the talus, lock it, bring it to neutral, distract, slight dorsiflexion, and then it's going to be a boom. Not a wham,
Right.
boom. The impulse is here. Okay, we don't want to affect the knee and the hip. So go ahead. Come on. Thank you, brother. Higher.
Higher on my hand?
Towards the ankle. There you go. I want you on the now you're on the talus. Go ahead.
I'm trying his foot.
Give me this finger. Now lock down over it.
Okay. Okay.
Distract. Dorsiflex. No. Yep.
Sorry. Yep.
Dorsi
Sorry.
and scoop.
Sorry. Got it.
Yep. Scoop.
Okay, good.
You let it go.
I can feel it. Let's expect he's going to go. He's not going anywhere.
Come on.
Okay. Scoop.
Yep. Better. More motion in there. Boom. Boom. Bring it. Scoop.
Okay. Like I pulled you.
But you're not pulling this way, you're scooping.
Scooping. Okay.
And that'll open that joint up. We good?
It's the biggest ring I've ever seen in my whole life.
Oh, that's the baby ring. Actually, the second baby. Yesterday, I was wearing the baby ring.
And the calcaneus is Achilles scoops.
Yep. So you can feel it. That's the pressure I want. So go ahead.
When you adjust it up to
Yep.
that.
Yep. I am covering the whole Achilles. And when you adjust it, you bring it to end range, it's just boom, quick impulse. It's not wham, we're slamming on it and quick impulse. We're good?
You're good.
Would you show the palpations?
Yeah. Give me 1 sec.
Yeah, no problem. On me or okay.
Doesn't matter. Okay. So subtalar, we're just going to support calcaneus. Okay. A little bit of support on the Achilles, and we're just going to P to A glide and A to P glide, and that's normal motion. When we do when we check the heel, a little bit of a lock, and just gentle, and you can feel that locks. Okay. Feel how open that one is? So calcaneal issue. So you can feel it because I'm going to have him fix it. That is the pressure I want on the Achilles.
What's the just straight down?
Yeah.
I feel it only on my anterior side. That's better. Okay.
Bring it to end play and gentle, quick impulse. Okay. Even more than you needed, but fine. And now we're going to recheck. Oh. There you go. Yes.
Josh here is severely limited in dorsiflexion bilaterally.
Okay.
And as I'm doing A to P motion, I'm not really feeling anything, but when I try to adjust it on him, he's not
Okay.
budging.
Relax. There we go. More scoop.
More scoop.
There we go.
So is it more like you're going superior with it?
With
too?
what?
With the move.
For
The
which?
scoop For the foot. So
For the talus?
yeah, for the talus.
So I'm locking it, bringing it in dorsey. Boom. Boom. There you go. Yeah. Dr. Hoppy? Yeah.
So my biggest issue was I felt like I could not get my hands around his
Okay.
foot. So she was telling me that she adjusts her husband like that all the time. She does one hand on it.
Fine.
Then I felt like I could hold his
Good.
foot because before when you
Remember
got
when
saying Dorsey
right?
person, I was just
Or remember when I talked
feel
about
like I'm
remember when I
holding a
talked about
plank.
being a Marine?
Yeah.
What'd you have to do? You had to improvise. You had to
improvise,
adapt.
yes.
You had to
Okay.
overcome.
Okay.
I told
yeah.
you, there's not one right way to do it.
Yeah.
There's incorrect ways to do it.
Do it.
But there's not one right way to do it.
Okay. All right. Yeah. That's right. And then we rise.
Guys, good?
You wanted me to say that. We rose up.
It's good. We good?
Hey, oh yeah, he's got exactly the same problem with his left ankle, exactly the same. We're just wondering, I was just teaching some of the students, we're going to go up the kinematic chain? Or,
All the way to the hip.
Yeah, you're going to go and show us that?
Yeah. Oh yeah. Oh yeah. We just have to start somewhere.
Yeah, cool.
Yeah. Yeah. We're gonna go next. We're gonna go tib, fib, and then we're gonna do femur.
So he's got a bit of a calcaneus that's really quite restricted. It's better than what it was. I'm not sure it's right.
Yeah, it's still a little stuck. Relax it. There it goes.
So Howard has decent preload as well, doesn't he? Like preloads it? Yeah.
Yeah. You got to.
Yeah, yeah.
Yeah.
This is-
Because if you preload it like that, that's when you only need a little impulse.
yeah, yeah.
You're already there. And it's like anything else. You know, you take proper line of jive and take out the slack on spinal adjustment, it drops in like a baby.
Some of the students were letting go, like
Right,
before. they-
Just like what's the most common thing they do when they start learning thoracics? They get good tissue pull. Like, oh God, you just slammed through all the tissue.
I feel you come up.
I will
I'm
get
like-
off the
I'm
table.
like,
Then I'm tensing.
Yep.
Yeah.
What's up? Thank you. Good? Everybody, hey! Everybody good with that? Any questions, concerns, comments, problems? Good. Yeah, well, do it if you're going to do it. Don't toy around. Shit. If you're going to fix it, fix it. Bilateral talar adjustments. Dorsiflex. There you go. Perfect. Nice. Pressure. Dorsiflex. There you go. Good. Less pull, a little more scoop, but good. Yep. Awesome. Cool. So, where is my original ankle boy? Yeah, you're ankle boy. You are no longer TJ. You are ankle boy.
Ankle man.
From now on, your Delta Tau Chi name is Flounder. Flounder. So, again, we took care of talus. Now, if it was an eversion sprain, we're going to do the exact opposite. We're going to take it from here down, same thing. All right. The same thing will happen with the calcaneus, though, whether you evert or invert, it will tend to get stuck superior. So, talus is clear. Next thing we're going to do is take a look at tibia. I will just now tibia is the only thing I don't do any sort of motion with. Why? Because there's really not a whole lot of motion to be had. Because it's going to rotate internal, external, okay? So I'm just going to bring it to neutral. I'm going to find tibial tube and just put my fingers down, and you can even see the internal rotation here compared to here, all right? The other thing that's going to happen, and we can just palpate it, you can motion it if you want, but you can feel, I mean, this one's nice. That one sticks out like a sore thumb, and it's tender, all right? I will take care of the fibula first and then the tibia. Why? Because I found out through time, sometimes when you correct the fib, the tib actually somehow resets. It does not happen the opposite way. I've tried it, done it for years. I don't know why. There's no rhyme or reason. As Dr. Riddle and I talk about certain things, why does it go that way? It does, all right? Why do you do it that way? Because that's what works. as far as the fibula, and I'll show it on both sides, but if you want to get closer to look at it, you know, please. Now, I will almost always do the fibula with the patient on their back, supine versus prone. Why? Because when you turn, and I know some guys like to do it and come in this way. The problem is when you go face down, rectus femoris likes to kick in and tighten down, all right? It doesn't do it when you're supine. You go prone, it starts kicking in, all right? So I will almost, I can't remember the last time I did a fibular head with somebody face down versus face up. Now, there's multiple ways you can do it, all right? There is not one correct way. I'm going to show you 2 different ways. Especially, I'm going to show you one person has never had an ACL injury. The other person's had an ACL injury. Why? Because the person that's had the ACL injury will guard the living shit out of you trying to bend their knee heavily, okay? They will guard all day long. Whether it hurts or not, it's an internal thing. They will just lock down. They don't want you to do it, okay? But when I do this, okay, like everything else, very, very quick, but this is not a well out in the country, and we are not going to pump it, okay? I hate that shit, all right? I'm going to lock in on the fib. I'm going to bring it to here. My hand is going to be midway up on the tibia, okay? Now, both for guys, but especially for women, one thing to remember with anything when you're adjusting, this is especially for the students, but doctors forget this too. There are 2 components to informed consent. One is written, the other is what? Verbal. Okay? Make sure you get consent, but also explain to the patient what the heck in bejesus your body's going to be doing. Because in the 12 years I sat on my board, trust me, I saw complaints where when you read it, it was a doc adjusting something, and in your head you said it, but the problem is he didn't explain to the patient, or she didn't explain to the patient what they were doing, and the patient thought it was a sexual attack, all right? So we're going to come here. Relax it. I'm going to come here. My body weight literally is going to be on your tibia, okay? I'm going to be leaning forward. So for the women, look, my breasts might be touching your leg, just so you know, all right? Are you okay with that? Just make sure they're okay with it, all right? We good with that? So I'm going to come all the way. You can see where my hand is. I am mid-shaft up, maybe even further up on his tibia. And we're going to come here, and he'll tell you, my body's pressing on it. And it is a quick impulse. That's it. Fibula moves. Okay? Do not do one of these. Okay? You're going to hurt them. Nice. I'm going to bring them back to neutral again. Check the tibia. It's still slightly offset, not terrible. Come down towards me. For this one especially, even more, for both, but for the guys, if this is a female patient, please explain this. I am going to have a hold of your leg here between my legs, all right? Otherwise, you do that with a female patient and don't explain it to, I guarantee you the next letter you get says personal and confidential, and in the upper left-hand corner is the board's address, all right? It will happen. So come down a little bit towards me. Perfect. Not little, too much. Right there. So I am going to control his leg 100%. The first thing I'm going to do is actually distract. And if somebody's got shorts on, you'll see the little bit of gapping between the femur and the tibia, okay, below the patella. I'm going to bring it here. All I'm doing is basically stopping the femur from moving. Why? Because if I just do this, the femur moves with me. If I do this, the femur moves with me. I don't want the femur going any further external because it's already external. So I'm just going to lock it. I'm going to pull down. I'm going to come slight. Now you can see I am maybe but 2 inches off the table as far as his leg goes. I do not bunny hop like that. We distracted. We've locked. We're here. That's it. We're going to come back. We're going to recheck. Dead freaking center. Get up and walk on that. How's it feel?
Good.
Yeah.
Ankle doesn't hurt when I go like that.
Shocker. Pair up. Let's check fibs and tibs. What's that?
I said you started a trend.
Yeah. I'm a trendsetter.
So for the fibula,
Yep.
was it the head that you were adjusting?
Yeah.
and moving?
Yep.
You just thumb contact
So,
right
no.
there.
Knife edge. locked in, all right, to here, 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 quick impulse.
What's your, like the line of draw, like
Straight through. And then when we're done, I'm going to show one other way to do it.
what's this hand doing? I mean, just in there.
This is locking on the fibular head. This is just stabilizing, and that's also your impulse hand. So this isn't impulsing, this is impulsing.
Real quick.
Yep.
We were right behind you.
No problem.
So you're finding.
So fibula, I'm just going to come and palpate, and that's tender. And you can feel when they're kicked back, you know. And you're also, if you try to motion it slightly anterior, it just doesn't move.
How's the side compare?
Doesn't hurt at all.
Yep.
Just the side?
Yep.
Okay. All right.
So,
How'd you do the tibia?
I'm going to show you. So we're going to lock it. Okay. Lock it. Bend. Midway. Body. Pressure so you feel that lockout, and then it's just boom. Very quick impulse.
And you're on Thanar pad?
What? No.
The right hand?
That's just a stabilizer.
Okay.
When I show you how to do it on an ACL, then there's going to be a pull.
Yeah. Okay. I learned it a different way where you can kind of.
You can, and that's the way I do. When you do somebody that's had an ACL, you'll just bend it and pull, because they won't let you bend it the whole way. They will not let you bend it, and if you try to, they will not be happy with you.
And the pulse it's gone posterior, so
Well, it's gone posterior.
Right.
But you're going to use this as your.
Oh, I see, and this is holding it.
Right.
Gotcha.
That's why I said we're not relax it. We're not pumping the well.
Right.
We're here. Lay your body right onto the leg. That way you brace it right out and quick impulse. There you go.
Impulse here.
Yep.
All right, tibia.
Huh?
So you're moving the fibula on the tibia.
Basically.
Right.
Yep. Sorry.
So to me, this is feeling like she's externally rotated.
Well, she is. Well, her femur is externally rotated, and we're going to fix that at the end. So, but what we do is we come to neutral, check the tibia, and that's pretty dead center.
Okay.
But we palpate the fib head, and that's a little tender.
Yes, no, maybe, perhaps, possibly.
Yeah.
Okay.
So we're going to lock right on the fib head. We're going to bend the knee, hand here. We're going to lean into it with the body. Quick impulse. Okay. We're not coming here. We're here, and we're using our body just to lock it out, and then that way it's just a quick boop.
So the right hand is the one, or is the one?
The one on the tibia is your thrust hand.
Okay. Coming on in.
Hey, hold on. You're a little high. Straighten it. The head of the fibula is right there.
Okay.
So
Feeling it. Okay.
knife edge right there. Now bend. Bend the knee all the way. Good. Lean into it with your body. And quick impulse. Okay. You're thrusting versus impulsing. Okay. Don't thrust superior. Boom. But get your chest right on her leg. There you go. Big difference. Did you feel the difference?
Yeah. Oh,
Yeah.
Yeah, my left hand is doing really slow.
Bring it back out and repalpate it. You're not always going to get a audible.
I understand that,
So-
but I also didn't feel anything
Yeah,
either. So
Just come right onto it. Yeah, it's not as bad, and we got motion in it. Yep.
That was close. I don't know if it's gonna need it, but yeah,
And you bring in.
he flex it a little bit more. Yeah, the knee.
It's just a quick drop.
So
Stabilizing here.
stabilizing here.
Yeah.
Yep. Give me your hand.
Okay. Feel it.
personally feel like he went straight down like this,
Yeah.
and there wasn't enough pressure behind the fibular head. Yeah.
You feel that?
Yeah.
That's how that's what I want you to feel.
Right.
See where I am? See where my hand is? And then it's just boom.
I think he's a little timid with this hand.
Yep. Do not be timid. Bring it in.
So we're pushing back here and.
Okay, and is that
Basically, we're using the tibia to make it go P to A.
okay? But so it'll normally be more potent.
More anterior. It'll normally be neutral. It can go anterior.
Okay. I guess whether or not you have it internally rotated or externally.
That doesn't matter.
Okay.
Right here. Halfway up on the chest.
Can we see how you thrusted and what, kind of how your drive was?
Feel where I'm locked.
Okay. Yeah.
Feel where I'm at.
Okay. So then you did kind of push it. So it's not. Okay. You can tell if it was like you're dropping.
No, I'm not dropping. I'm using my body weight just to stabilize everything.
Gotcha.
Can you help me out with that contact and leave this?
For the fibula?
Yeah.
Find the fib head.
Yep.
Lock it.
Right there.
Right there.
Okay.
Bend it. Get to end play. And then, boom. Quick impulse.
Okay. I had a different
Now,
contact before.
the other way you can do it, and I'm going to show everybody. Let's say he's an ACL guy. You bring it to here. You lock here. You support here. You pull.
Okay. I've done that. Yeah.
That's the other way to do it. Because an ACL patient will not let you get to here. I guarantee it. They won't let you do it. Okay, or even somebody that's got a meniscal tear, that sometimes they won't let you get there. So just come here, lock it out, brace the femur. Boop. Nice. Superman.
Want to show us your tib?
Huh? Yeah.
To do the tib? How you're doing it? Because we're.
So you can see where that tibia is.
Which one?
This one, compared to this one. The internal. So, lay back.
So you're distracting and externally rotating?
Distracting, bracing the femur, bringing it here.
You're bracing right below the kneecap.
Yeah. I'm grabbing your femur and just bracing below the kneecap just to protect the patellar tendon.
I thought when I was watching before, I was like, here.
You can come up here too. I just like to lock this whole thing down. So boom, boom, and just a quick drop.
Where's your pressure coming from? This hand or this hand?
This hand. Boom, boom. There it goes. Dead center.
Did you feel like a cavitation?
No, you won't feel a cavitation on a tibia. You might feel it on a fib, but if you don't, it's probably, I was going to say, you feel a cavitation on a tibia, that's probably not good. Excuse me. Yeah, NCMIC, we have a problem.
So, hypothetically.
Hypothetically, if I cracked a tibia, yeah.
Can you show the students how much preload you use on the tibia, on the fibular adjustment?
Yeah. So relax this, let this drop. That is how much preload we've got. And then that way at the end, that's it.
So your force is coming from this hand.
Absolutely. Now, remember I talked about ACL? They won't let you do that. Knee to where they're comfortable. It may be here. Okay? They're not going to usually won't let you go the whole way. Brace. Just protect. Pull. Boom. It's just a straight P to A pull. That's all. Right.
So, showed the guys how much preload he was using.
And instead of doing the pump, that's when something like that with the body, and it was great. It's just it's a really quick, very short lever.
With somebody who's got knee problems, say if they got swelling in the knee and they can't flex it
Right.
be able to do the fibula.
Okay, bend this. Same thing like if there's an ACL, okay, where they're not going to let you go all the way. Bend the knee to wherever you can bend it that they're comfortable, okay? Just locking the leg down, supporting this, straight anterior tissue pull, boop. Yeah. Yeah. I did it the other way forever until I had an athlete with an ACL injury that wouldn't let me do it that way. And I went, well, what the hell am I going to do? And I said, well, let me try this. I said, relax. I said, I'm just going to come right to here. Does this hurt? No. Bam. And it just went boom. And she was like, I said, we okay? She goes, yeah. And I said, get up. And she bends her knee. She goes, holy shit, I have motion in my knee. You know, it's like, yeah. And she was like, the other guys just wanted to slam it. Yeah, I get what they wanted to do, but they didn't take you into consideration. You know, you have to take your patient's limitations as well as your own into consideration. You know, it's like I say, you know, a 5'2", 110-pound female is not going to do a side posture push, lumbar push, on an NFL offensive lineman. They can't do it. You know, it won't work. So what do? Get a spinous and do a kick pull. You'll move it. I always say, use their body weight to your advantage. You know, they're that big, do an anterior. Use their upper body and let it do all the work for you. Yeah, exactly. And I tell people, one of the best female sports chiropractors I've ever seen adjust, Sherry Lachaume. You know, Sherry is what, like 5'2", 110 pounds soaking wet. You know, she's the head of medicine or head chiropractor for USA Taekwondo. You know, she's done a million things. I've been adjusted by Sherry. She is so damn fast.
Really?
Yeah. But she knows her, but like she said, she goes, I'm not going to take a big guy and hurt myself. Yeah. You know, you do what's best for you. And that's why I say there's no 100% correct, there are incorrect ways to adjust. There's not necessarily everybody's correct way. You have to do it to you. You know, and that's why it drives me nuts. I see some of these instructors teaching things. This is how you do it. Dude, you're 6'3" and 260 pounds. That's how you do it. You don't tell little Ann over there to do it the same way. It's not going to happen. It doesn't work that way. You know. Cool. Make sense? We're good?
Thrusting from the inferior
I want
hand.
you to do me whenever you're.
What, you want me to adjust you?
Yeah.
Just your knee?
No, the whole shebang.
We'll lay on your back.
You said the.
Lay on your back.
The
Relax. Relax. So that's clean. That's clean. Tibia is definitely a little rotated. Little tender?
Yeah.
Okay. So we're going to do the fib first. You okay with me? Okay. You okay with me leaning on this? Okay, relax it. Scoot down a little bit. Okay. Relax this. Come a little further.
This.
Yep. Okay, there we go. Okay, I got you.
Okay.
Now, you feel that gap there? Now?
Yeah.
Okay.
I also feel it up here.
You're going to feel a little bit there. So we got gap. We're going to bring it back from medial. I'm going to support this. There it goes. That's all the pressure you need. Now get up and walk on that.
Get up and walk.
Rise up! Yeah.
Keep going. What else are you going to show us?
We're going to get there.
Thank you. I'm now hanging out in your room again.
Love it.
I think we figured it out.
Okay. Good. Talk to me.
Do you want to do it one more time so that?
I just want to make sure you're. When I was watching you, the thrust looked lateral to medial on the.
For what? No. Straight P to A. Or A to P. Yeah. Your line of drive is straight through.
Are you locking this?
Yep.
now?
So, relax. Coming in and locking right on the fib head. Then I'll bend the knee to it. I got you. And then follow through. Okay, now, the other way, and I was talking about it, and I'll show it in a minute. Let's say she's one of these ACL patients, or a fresh hot knee, swollen. We can't bend it, there's too much in there. Lock it, get it to wherever you can get it to. Lock it down, boom. And just pull.
The assessment, you just went on the tibial tube or whatever?
Yeah, I'm just looking for where if it's off center or not. Yep. Yeah. Make sense? Cool.
Can I feel that? Get a feel for that?
Yeah.
I also have right leg trouble, so you're fine.
Good. I want a better table, though.
Better table?
Well, just one that I've got a little... Come up to the big table up top. Just for the fib, at least. Which one?
Right one.
Okay.
They'll probably be both, though.
Relax. What's going on, brother? How are you? Good to see you. So that's okay. That's okay. Relax. Yeah, locked.
Yes.
Okay.
That's exactly what it feels.
Relax it.
Is it too high?
No. Relax it. There it goes. That's it. It's too high. Now, I can do the tibia the same way here. I can just lock here, because you can feel you're a little internally rotated. I can lock. Dead straight. Hey, anytime, brother. We good? Ladies and gentlemen, any questions? Okay, real quick. I talked about also, and I've showed some people, let's say you've got either a fresh hot knee, it's too swollen, you can't bend it, or again, like I said, those ACL people who don't want you bending it like that. Real simple. Somebody come right here. Anybody? Just bring it to where it's comfortable. Support and lock this down. Stabilize, come on the fib head, boom, straight pull. Okay? Because like I said, those ACL guys and gals, they don't want to be, most of them won't let you come here. They will start guarding and fighting you all day long. Or again, it's a fresh hot knee, there's too much swelling in there, you can't even get it to end play. Well, what do? Then that's how I figured that out actually, because I had somebody that wouldn't let me do it. And I was like, well, we got to move this. And she was like, I don't want you to move it. And I was like, well, we got to move it. And so I just sat there and was, how are we going to do that? I said, well, let's pull it. Bam. And it just unloaded, and she gets up, she goes, oh my God, my knee hasn't had that much motion in forever. I was like, well, it's because everybody's trying to slam on it, and you won't let them, and they shouldn't let you. So, questions, concerns, comments? Cool, we're cruising. I love this. We might end early. And yes, you still get credit. All right, so we talked about internal. What did the femur do? External. How much internal rotation should the average, and I say average because Dr. Rose is here and we know that athletes do not have average range of motion, but average internal hip rotation should be what? 35 to 40, depending. And I say, again, average. If you've got a martial artist, who the heck knows what it's going to be? You have a gymnast, you don't know. And this is why you, with everybody, you want, when they're your patients, especially athletes, if they're seeing you from a pure performance level, you want to note what all their rotation, what all their range of motion is. Because I had one, okay, a gymnast who got in a pretty severe car accident, all right? And when she had the IME, well, all her range of motion's within normal limits. Yeah, for the average person walking down the street, all right? Not for her, all right? Or a wrestler, or anybody, like I said, a martial artist, anybody that's got this shoulder, same thing, all right? Normal external rotations, what? Of the shoulder. Goes to what? 90. What's the average external rotation of a Major League Baseball pitcher? 120 or more, okay? Pedro Martinez was almost 140. So normal for the average person, pitcher, all right? So same thing. I got in a bad car accident, all right? I had a bad shoulder injury. I had an IME. Well, his range of motion is normal. No, it's not normal. That's not what my range of motion was. My range of motion was 120 before I had a shoulder injury, all right? It got repaired. I went through rehab. I have normal range of motion again. My normal range of motion. So remember, normals are only normal to the average person, all right? You got to know who you're dealing with. So, so hip. So bend, 0, 5, 10, 15, 20, maybe 22 if we push it. All right. Now, as far as the hip goes, I'm going to show you two different ways. One that I was taught by my PT, all right, and one that I was taught through MPI, all right. I will not show you the way I was taught in school because I do not grab a leg here and go, whoop. All right, you just affected the ankle, the knee, and the hip all over again. If we just corrected the ankle and the knee, the last thing we want to do is put a thrust back into the ankle and the knee. All right, so the way I was shown by my DPT, come here. Now, you can either sit on the foot. If you sit on the foot, again, what are you going to do with the patient? Tell them what the heck you're doing. All right, I'll usually just lock it down. I'm going to come right above the knee on the femur, distract, relax. Quick impulse. Relax it. This is where we were. This is where we are. Normal range of motion. The other way you can do it, turn on your side. I'm not going to actually do it because that one doesn't need it. Come all the way to the edge. Set them up like a normal side posture adjustment. Calcaneal, find tube, come right on it. We're going to lock down and rotate so that your line of drive is going to be right down the femur. And all you're going to do is, boom, come right through it. All right. Now, I had earlier this morning, one of the females was like, okay, what happens when I have that patient like you had with Mark Henry, who's a behemoth and has legs like this that I can't even get my legs around or or anything? And I said, well, think about it. I said, what did I tell you to be? She goes, a Marine. I said, which means what? She goes, improvise, adapt, overcome. So how are you going to do it? And she sat there and looked and thought. I said, get a towel, wrap the towel, and use the towel as your lever. I said, don't do it around the neck like somebody else does on Facebook. All right, and I knew that's why you started laughing, Friedman. Yeah, we do not do ring dingers on the neck, okay? But, you know, in this case, doing it to get leverage on a hip is one thing. Yeah, we talked about it earlier. I, to this day, do not know how that guy has a license and isn't in jail. Especially, we just talked about informed consent or lack thereof. Don't do it, don't do it, don't do it. Wham! Ah, my arms are numb. And he still has a license. It's a good thing I'm not on the Texas board. So, cool. Let's run through the hip and go from there. So make sure you check it, see if it's restricted. If it is, walk through it. The fucking humdinger. Oh my God. Yes.
Hey man, why are you talking about my neighbor like that?
Your neighbor should be in fucking jail.
Yeah, I know. So if it's not internal rotation, what if it's external, like for
Same thing.
You use the
Same exact thing.
Okay.
We're just resetting it.
Okay.
It's going to boom, reset.
Okay.
Doesn't matter.
I didn't know if it was different internal, external.
No, because it's a quick, it's a long axis distraction, just using a short lever, not a long lever.
Okay. Cool.
Now, what about when you use like this?
That's for the hips.
So for like this position right here, and we were talking about the young lady that has like the pain in her hip.
Mm-hmm.
That's me. But a side posture and pulling, like gapping that.
Sure. I was already messing
Okay, because they're doing long axis. Come over here. Lay on your back. Which hip? So first things first, relax this. No, you're good. Relax this. You have normal range of motion. So why are we going to adjust it? So the question is then, why do you have pain? What do you feel? Feel that.
Oh, yeah, no.
Feel that lock?
Yeah, I feel that lock.
What do you guys see with my thumbs? See how anterior this is? So you have an anterior rotated pelvis. Lay on this side, and I'll show you why it hurts when they're adjusting you. Because they are adjusting you like this, aren't they? You have an anterior tilted pelvis. What is this doing to the pelvis? Doing it more anterior. Straighten the bottom leg. Straight.
Hang on, I can't. I just got to see back. Okay, there we go.
Let this come off the table. There we go. Oh, motion. Relax. Oh, look, free hip. Had nothing to do with your hip. This is why we examine and check. anterior. Yeah, just boom. So it was an AS pelvis.
Okay.
If we're going to talk in Gonstead terms, versus a PI pelvis, right?
Okay.
But
All right.
We have both sides of the leg.
yeah, boom. Yep.
So it's either
Here.
Yeah.
Down.
Down.
Rotate.
here, down, rotate.
Yep. Knee up. Straight down the femoral, down the femur.
Down the femur.
There you go. Perfect.
Oh, well.
That might happen too.
For the P to A fibular, what about the modification if you almost like put it in like a headlock kind of thing and then?
It's fine. Again, improvise, adapt, overcome. Okay, if you're doing the femur, stop. Here, lock, rotate, line of drive is straight down the femur. So watch. Right there. Boom, boom, wham. That's not moving.
That's just, and that's an issue too. Okay. Oh, you said you have a previous hip thing. Yeah, pain. You said you had something going on with the hip.
If you need me, let me know.
This way, right?
For what?
Internal rotation.
Of?
You twisted this, the femur.
So if we're doing the femur, it doesn't matter. You do not have to put any rotation into it. Okay? When you gap it, it's just going to reset.
Oh, okay.
Okay? The only rotation is if you're doing it on the side. So turn and face me.
So you just grab it.
Come to the edge. Relax your head. Boom, boom. Right there. Lock. Rotate. Straight down the femur. Make sense? Yeah.
Did you have any rotation?
No, straight to strap. It'll gap and reset.
Yeah.
Relax the hamstring. I come up, pull.
It's the you lean back.
Yeah.
I had it and like pre-tensioned it.
Just like anything else, you got to bring it to pretension.
Okay.
Try it on this side too.
Come through, come back.
Yeah.
Like that.
Yep, and now pull. Big difference.
Okay.
That's what it is.
I think that may have answered some of it. I felt like when I was pulling his pelvis.
Yep,
up a lot
no.
more. So you kind of.
I come slight superior, okay, or slight anterior, distract, and I lean back to tension, and then boom.
Okay. So I felt like I was just like lifting his
Yep,
pelvis
no,
on
come
the
up,
ground, so.
lean back. There, you big difference when you bring it to pretension.
So I think I missed the line. So this one.
On the hip,
Yeah.
stop. Come a little more on your shoulder.
So I think right there, like that.
Your stick's out nice, so it's easy to get to. Lock it, rotate, line of drive is straight down the femur. Boom. Yep. Perfect. Yeah. Feel the difference?
We still have a little bit of trouble with preload. You need to preload a hip a little bit, don't you?
Absolutely, always.
Let's show these guys just the preload pressure.
Yeah.
Right. So I stepped out for this portion of it. So
So if we're going to do it the MPI way, lay on your shoulder just a little more. Good. Come to the edge. You won't fall. Boom. Boom. His sticks out like a sore thumb. It's nice and easy to find. So we're going to lock. We're going to rotate. Okay, because our line of drive is going to be straight down the femoral. And then you feel how I'm really preloading it. And then that way, if I kick now, the hip's just going to unload.
Yeah.
And it's very gentle, but you feel that load.
Howard, would you better set up?
Yeah, I would love to.
On the supine one.
you're looking for the greater trochanter.
Yeah, I absolutely am. I'm right on the trochanter. And if it's rotated in any way, shape, or form, the trochanter is going to be tender. I don't care if it's internally or externally rotated. Trochanter is going to be tender.
I'll call it trochanteric bursitis.
Right.
Call it that.
Contact on there, and then get up to do your kick.
This became my key of treating hip pointers. And the hockey players. I started doing this, and the hip pointers were healing like that. And everybody's like, how are you getting hip pointers to heal in a week?
Okay, now, can you hook on your back and how it's going to set up on you with the supine?
Right.
Relax this. Let me have it. Hamstrings loose. That one's good. That one's a little stuck. Boom. Lock. Hamstring loose. Loosey-goosey. Come on. There you go. Here. Slight anterior. Pull. Bam.
Okay.
Quite a bit of preload.
Yeah.
Not
But
excessive.
no, but I'm here. Not here. You're not going to get it. Here. You'll feel it. If you're there, you have to yank on it. You're going to hurt him.
Yeah, come on, let's give it a try. Behind me, Satan.
Yeah, bend over.
Want to try, so I have limited internal
Okay.
on this, so we don't really understand the hand grip.
Okay. Lock.
Limited internal on the
Yep.
female.
And whether you're limited internal, external, nothing's going to change. Here, superior, you're a little anterior. Load. You feel how?
Now I feel it.
Feel that load?
Yeah. He's leaning back.
I'm leaning.
That's the difference. You're using your arms. Okay. You were pulling. You got to use your
I'm
body.
using my body. This is a big freaking chunk of meat. All right. If it's a 110-pound little girl, it's different.
Yeah. You were still sideways but leaning back because you're. Oh, okay. Never mind. You had your left
Yeah, you
hand.
can actually feel it's like you create a fulcrum.
I was like this. Okay.
Bingo.
Cool. Thanks.
Yeah.
So turn your leg so the knee's on the inside of my foot.
No.
Yep.
There you go.
There you go. Now just.
There you go.
I'll just lean back.
Different?
And do it. Do it. Yeah.
There you go.
There you go. Money.
Much easier, isn't it?
Yeah, we're not getting anywhere.
This tree trunk is not moving.
It doesn't work. How we doing?
Good.
Okay.
Grab
Lean.
here.
Once you lock,
Okay.
once you come here, slightly anterior, lean back now. Lean. Now you feel that come into end play? And that way when you boom, you've got it there. If you're on top of it, how can you come that way?
Oh, okay.
Yeah.
We're doing okay?
Yeah, he had hip pain, but I think he has a femoral neuralgia. I don't think he has a hip problem.
Now, the one other thing he can have be his hip pain. Check his pelvis. Check his pelvis.
Well, he's got weakness in the hip flexors
Lay on
and
your back.
weakness in the psoas. And he's got a positive slump.
Feel the easiness. Feel the lock. So he's got a rotation left anterior. Lay on this side. Come to the edge. No. That brings you further anterior. That brings it back posterior. Now we can come here and move it.
But now we should see if the other test changed.
Yeah,
right?
absolutely.
All right, so you need to resist, okay? This one's fine. We go here again, up. No, I really think it's femoral nerve.
Yeah, I think you're right. But we had to clear pelvis first to know.
Plus, he's an over-manipulated chiropractic student.
Shocker. That would never happen to us.
Yeah, my neck still doesn't hurt.
Yeah. I can't tell you how long it took me to stabilize.
I cavitate every time I turn.
Oh,
You said you did a SFMA too, got certified in that. What else? Do you do much like DNS or anything like that, or have you?
I haven't yet.
Yeah. Do you use it? I mean, or
Play with it a little bit.
yeah. Okay.
Yeah.
I'm just curious, like what all.
Yep. Yeah. I just don't think you can ever have enough good information.
Right.
You know. Now, at the same time, you don't want to spend an hour and a half examining somebody. All right. So you pick and choose what to do, how to do it. Boom. You know. But when you get good at it, you're going to be able to run through it. You know. I can run through a whole lower extremity eval and adjust them in under 5 minutes. Okay. Not 22 seconds. Okay. Under 5 minutes. All right. But that's because I've been doing it for 21 years. All right. You guys, I'd say probably 15 minutes, and once you're really comfortable with it, you'll be able to do it. Okay. When we do upper extremity, it takes a little longer because there's a lot more to check. You know. And that's a whole nother story. And that will be when I come back and do the full seminar.
What's that?
We're working on it. Yeah. We're working on it. Cool. Does it make sense? Does that all make sense? Okay. Good. Yeah. We're good? Okay. Questions, concerns, comments?
Not yet.
Okay.
We're good.
Well,
I think.
we've gone through everything.
I was gonna say, with your leverage on doing it for here, for getting the hip.
Okay.
Like vertically challenged. That one's just
Doesn't matter.
Doesn't matter.
Vertically matter. Scoot up just a little bit. Because you're just gonna lock, and you're gonna lean.
And it's more of just
So
practice
up,
or like
and then you feel how that's at end play?
That's different. Because I was thinking it was
No.
it's more back.
Lean back. Because when you get it to that load, it's just tick. If you don't have it preloaded, now you got to go through everything.
Makes more sense. Okay.
Make sense? Good. We're good? Makes sense?
Yeah.
All right.
I think we're good.
Awesome.
Can you show me the hand contact on the fibular head one?
Yeah.
The one where you're leaning into it, the fibular head.
Okay, sure.
Just because my thumb felt like my thumb kept on getting in the way.
Leg. Knife edge. Lock it.
And your knife edge right on the posterior aspect of the fibular head.
And I'm still got pressure there, don't I? Now when I come here, it's locked. That way I can come right here, and all I have to do is boop.
Okay, so this doesn't do anything besides break.
No, now
This
let's suppose it's that, like I said, that ACL
Right.
or that new hot knee. Brace here, okay? Same area, except I'm just gonna lock here.
Yep.
I'm gonna protect the femur.
Yep.
Pull straight through.
And I was taught it prone, but the reason why you don't do it prone because rectus femoris
Rectus kicks in.
activates, and there's no way you're going to move it from there.
Bingo.
Yeah.
Yeah. I had an athlete I was working with literally quad pain, and if here, I could do this all day long. I turn her over, I could get her to here. Why? Well, what did that do? It told me what muscle was the issue instantly.
Right.
That it wasn't any of the vasti muscles, it was rectus. So I just went after it with factor and a little cupping. Bing, you know. And that's the thing, you got to remember, when you're dealing with this kind of stuff, you still have to address the soft tissue. All right? And yes, I occasionally teach with that man. Okay? I'm not on their payroll. I do not get paid to promote them. That is probably, as far as technique goes, because I don't consider SFMA a technique, it's an examination, okay? Okay, but as far as techniques and things that I've done and learned, that has changed me as a sports chiropractor more than anything in the last decade and a half, all right? And, well, it's true, and that's the thing, And if there's one thing that people know about me, I don't blow smoke, I don't bullshit, all right? Either I support something or I don't support something. Whether I'm paid or not paid, it doesn't matter. And if I'm getting paid, I definitely have to have all my eggs in the basket for me to put my name behind something. I came back from Factor, I was like, and I had a patient that came back to me who had seen 3 other chiropractors for hip pain. And they're adjusting. I'm going through all my extremity stuff going, dude, I got no restrictions anywhere. So, but I get in on TFL and she lights up. I get in on glute med, she lights up. So all I did was I did factor work with her doing clamshells and reverse clamshells. 2 treatments, pain-free she was running. In any other IASTM course I had taken, nobody would have shown me to do it through active motion and in a provocative position. We were taught to do the opposite. You know? So, and it does. When I sit there, when I talk to other practitioners about it, they're like, you do what? You treat in the what position? I go, I'm telling you. I said, and if you want the research, I can get it for you. It is what it is. It's taking me a third of the treatments than anything else I used to do. So,
Very cool.
we're good?
Yeah, I have a question for you.
Yeah.
When I do the internal rotation, I get a lot of cramping on the outside of my hip. Is that like
Lay on your back.
I'm probably actively trying.
Okay, you feel how easy that goes?
Yeah.
What do we feel here?
Tight.
Come to that table.
Where do you want me?
Head up there. So, if I'm coming this way and it's locked, how is the pelvis rotated?
It's left rotated. You're saying like
Left what? Anterior.
yeah.
Lay on your side. So what are people going to do? We're going to do, it's anterior. You're bringing it more anterior.
Yeah.
Last thing we want to do. How about we bring it back posterior and come here and adjust it and lay on your back and get free motion in a pelvis. Now try that motion. Yeah.
Yeah.
It's not cramping.
Yeah.
There you go.
That's cool. I've never seen that with like a straight leg. It's interesting.
Yeah. So as I said, there's things you get taught in school, and then there's real life. You know, think in your head when you're, no matter what you're doing, when you're thinking about the line of drive and how things are moving, think about where if there's a restriction and you're putting it further into a restricted state, how are you going to get motion? Okay, you got to take it out of the restricted state. It's just like we were talking earlier, I was showing a couple of the students, you know, easy way to do, because traditionally chiropractors hate having to deal with transition segments, okay? T1, CT, and TL. And one of the, okay, you'll get patients that come in chronic low back pain, right? Right at the SI joint. And you adjust them, and yeah, they get a little relief.
It's kind of a hypermobile.
Okay, yeah, maybe. Okay. What muscles trigger points refer to the SI joint?
QL.
Where's the QL insert?
TL junction.
Adjust T12. And all of a sudden QL lets go and they go, oh my God, my back feels great. Dr. Carl.
Cool.
All right.
For the TL, is that like, cause like I kind of do like the Mopal type of stuff. Do you mostly do like, because the one they mostly teach you is the anterior.
I do it face down. Tender? Huh? Yeah. Okay. Remember, what's the angle of this facet primarily? Okay. Okay, here's what happens. Most people come here and try to do T12. Yet you just hit it. You've got to go 90% I to S. Deep breath and hold. There it goes. Why the deep breath and hold? What did it do at that junction? Open, gapped it for you. Because you're going from kyphosis to lordosis. Take the deep breath, it opens, it gaps it for you. And then dink, and how little pressure did it take for that to move?
Yeah, not much.
Exactly. You don't need to slam on it. And then, like I said, now stand up. Lo and behold, a soft QL.
Feels nice. Thanks.
Ladies and gentlemen, and I use that term loosely with some of you,
Flattery will get you.
Absolutely. And guys, any questions at all from anything we've gone over? Going once. Going twice. Cool. I'll hang around for a little while longer, but as far as I'm concerned, y'all are done.
Hey, bro.